So with both the front arm lines and the back arm lines, each are separated into superficial and deep. Superficial or closer to the surface, deep or deep. When we look at the superficial front arm line, we have the pecs, we have the lats. From the pecs to lats, we go down into the common wrist flexors, and they come out into the pinky, the hypothenar eminence, flexor pollicis longus. We have the carpal tunnel, the palmar surface of the fingers. We have the iliac crest because of the lat involvement. We have the medial epicondyle of the elbow, the medial humerus we're going to run through here, and we have the costal cartilage. And then we have the medial portion of the clavicle. So not very many muscles, lots of bone involvement, not a lot of other structures with this one. The deep front line, obviously a little bit deeper. This is where we have pec minor, subclavius. We get into the biceps, down into the wrist, the deeper wrist flexors, flexor pollicis longus. But the deep front line takes us to the thumb side, the thenar eminence. Superficial front line takes us to the lateral side of the hand. Deep front line, subclavius. My pec is in everybody's deep front arm line. Pec minor. Long head, short head of the biceps, coracobrachialis, brachialis, supinator, and then, like I said, the hypothenar muscles that take us down into the pinky finger. Superficial pec minor, lats, and then all of our flexors at the off of the medial epicondyle. Clavicles involved in both. The coracoid process. We're going to come back to this one. I don't know why I'm poking on my chest for the coracoid process. Coracoid process is, again, an area, one of those areas that we don't assign enough value to. Shoulder stuff, we automatically think biceps tendon, we think the importance of the rotator cuff, and all rightly so. But one of the areas that we underappreciate and undervalue is the coracoid process. We have a lot of, if we think about what attaches the coracoid process, pec minor, coracobrachialis, short head of the biceps, there's a lot of tension on that coracoid process. And because it's sitting in the front, one of the things that we oftentimes completely neglect, we just think, okay, coracoid process, that's the scapula. That's the anterior part of the scapula. So we oftentimes, when we think scapula, we go straight to our rotator cuff muscles. We address somebody has a scapular problem, winging of the scapula, rounding of the shoulder. We're addressing scapular things because we think scapula, this is our scapula. It is, but we also have this, the coracobrachialis. And it's what ties the scapula into our front arm lines, specifically that deep front arm line. Radius is involved in the deep side. We have the iliac crest. Yeah, the iliac crest is part of the arm lines because of the lat involvement. As far as other tissues, at the wrist, we have the radial collateral ligament, cartilage, the costal cartilage, the thoracolumbar fascia in our low back, and then the carpal tunnel. So once again, we think arm line, we're just thinking here. Because of the lat's involvement in the superficial front arm line, we have a direct tie-in to what's going on in the low back. Thoracolumbar fascia down into the sacrum. The actual lat itself attaching onto the posterior aspect of the iliac crest. So have that person with low back that comes in complaining of low back pain, and we look at their low back and nothing's jumping out at us. We might need to expand our thinking and take a look at that superficial front arm line. I've had several patients where we've had back pain, and somebody comes in with, and this is why we can't fall into the trap of this person's coming in with back pain, let's just look at the back. We have to consider everything. I've had several patients where they've come in, their issue is back pain, and we do all the special testing for the lumbar spine, range of motion's fine, all of the lumbar special tests are fine, nothing explains this low back pain. So obviously they're making it up. I've had several patients where on a whim we've gone up and we've actually looked into the arm, into the biceps, into the deep flexors, and found issues. And by addressing those issues, either range of motion issues, trigger point issues, tissue issues themselves, by addressing the arm, all of a sudden, after a little bit of work here, their symptoms of low back pain goes away. Now, we can tie that into the lateral line, through the functional line, through the lat, down into the knee, into the pelvis and everything. But when we start talking about the superficial front arm line, we have a legitimate actual attachment into the pelvis through this line. So if somebody has bicep issues, we could see an effect all the way down into that lumbar spine. Somebody had our UCL patients, UCL reconstructions. It's not uncommon for them to experience a period of low back pain that's hard for them to explain and hard for us to understand. Obviously, you're not as active now and you're sitting more, and the reason your back hurts is because you're sitting more, and we try to assign all these other reasons to why they're having it because we don't consider the direct anatomical connection from the medial elbow, through the biceps, through the lat, down into that thoracolumbar fascia, into the posterior iliac crest. If we do that, we can actually get into and address the low back. Deep back arm line, again, superficial and deep. On the backside, levator scapula, the rotary cuff, both of our rhomboids, triceps, a little bitty muscle, the anconeus, and then we get into the extensors. Deep back arm line takes us to the pinky side. Superficial back arm line, not very much here, just your traps, just your delts. There's 5 sections of your traps and 3 sections of your delts, and then the extensor mass off the lateral epicondyle, that take us down into the thumb side of the hand one more time. From a bony standpoint, we have transverse processes in the deep back arm line, all the way down to our lateral border of the pinky. Superficial back arm line, we have direct tie into the occipital ridge. So we have a direct tie-in to the head and into the neck with the arm line, or with our back arm lines. So again, we have to take that into consideration anytime we have somebody with neck pain. Is there a direct tie-in to the back arm lines? What's going on within the back arm lines from a range of motion standpoint, from a special testing standpoint? Do they have anything going on in their arm lines that could be influencing and affecting what's going on in the neck? So we just need to expand our thinking just a little bit on that one. There's not a lot of other tissues within the arm lines. The deep back arm line, we have the periosteum of the ulnar and the UCLR, the ulnar collateral ligament of the wrist. Not at the elbow, it's up the wrist. There's nothing in the superficial back arm lines. You need to remember, we have arm lines, we don't have leg lines. And there's a reason why we don't have leg lines. The reason that when we talk about the lower extremity, we're talking about the spiral line. We're talking about the lateral line. We're talking about the superficial front line. We're talking about the superficial back line. And the reason being is the overall function of those limbs. Our legs are directly tied to our pelvis. Our legs can't work in isolation because the entire function of our legs is to move us around in the world. The entire function of our legs is locomotion and changing levels, getting up and getting down. To do that, the pelvis and the lower extremity have to work together. The pelvis and the trunk have to work together, which is why when we talk about the lower extremity and the legs, those lines encompass the legs, the pelvis, and the trunk. The arms are completely different. Whereas the legs are designed for locomotion, the arms are designed for mobility. So because of that, yes, we have some direct tie-ins to the neck, and yes, we have some direct tie-ins to the lumbar spine, but essentially the arm lines need to be able to function independently. We're moving we're adjusting where our body is in space, and we're then taking our hand and putting our hand and interacting with the world around us. We need to be very precise with our hands, less precise with our lower extremity. So as a way to increase precision, arms are very specialized, and arms are able to work much more independently than our legs are. If you hurt your arm and you're in a sling, how much does that impact your day-to-day activities? It's your left arm, not a whole lot. It's your left, and when I say left arm, because your left arm, I can still start my car, even if it's a push button. I can adjust the gear shifter on the column, or I can adjust the gear shifter here. I can open the car door. I can do all the stuff I need to with my right arm. Now, if my right arm's in a sling, now it's really hard for me to shift. I have a manual transmission. It's hard for me to get my truck into gear. All of that stuff's more challenging. I can still do it. It's going to be a little bit annoying. Getting either arm, getting dressed is going to be annoying just because, it's a little bit harder. Brushing your teeth, combing your hair, just day-to-day self-care stuff's going to be a little bit tougher. But it's not going to be that big of an inconvenience. But if I hurt my left leg, I'm on crutches. You get to walk. Here's your choice. We get to immobilize your non-dominant arm in a sling for a week, or we get to immobilize your non-dominant leg for a week and you're on crutches. Which do you pick? The arm's a little bit, if I have to pick which one I'm going to get rid of, the arm's a little bit easier for me to get through my day-to-day activities. Now, if I'm not having to leave the house and I can stay home all the time, I'll just sit on the couch and leave my leg propped up. I'll give you both arms so I can play Xbox. I want to be able to work on the phone in one hand and control the remote on the other. But if I'm having to actually get up and move around and go through my days, being on crutches is a big inconvenience. So the arms are designed for mobility, not for locomotion. Because of that, they have lots of degrees of freedom. We need lots of different ways to create stability within that. Variable lines of control stabilization. That's what the arm lines allow us to do. The arm lines are named by where they pass in regards to the shoulder. So front arm lines obviously are on the anterior side of the shoulder. Back arm lines are on the posterior side of the shoulder. Posturally, they're not part of the structural column, so they don't directly affect the posture in what we're doing. However, they have a direct reflection on what's going on with our shoulders, and that can have a carryover effect into our posture. It's one of the reasons why our shoulder position has such a direct and such a big impact on our ability to utilize the rib cage, to access the diaphragm, what's going on with the neck. If we have rounded shoulders, it's going to pull on the neck through the back arm lines. If we have rounded shoulders, it's going to affect the pelvis because of the front arm line through the lats. So while it doesn't have a direct postural function, other than maintaining shoulder position, it does have what our arms are doing have a very significant impact on what's going on in the pelvis and what's going on the neck, which then can affect secondarily all of our other fascial lines as well. From a movement standpoint, again, not locomotion. It's all about being able to place our hands in space, find precise movements. The ability to type on a keyboard without having to look, be able to do all of that takes very precise movements that we can't accomplish with our lower extremities without significant training. Arms have a direct connection with the eyes. Hand-eye coordination, we hear that a lot. Being able to put your hand exactly where you need it, being able to throw something, be able to catch something. Our hands and our eyes have to work very directly with each other to pull that task off. And then they do have a connection with our helical lines, which is the spiral line, the lateral line, and our three functional lines because of those lines tie into the scapula. So we see those lines having to work very, very intricately together. Less with the cardinal lines. So yes, the pec is part of the arm lines. The pec is also part of the front functional line. We don't see that necessarily that direct attachment to the front functional line, but it can have a secondary impact on that. Shoulder position is going to have an effect on what's going on in the superficial front line. Shoulder position is going to have a carryover what's going on in the superficial back line, but they're not the direct carryovers like what we see affecting the lateral line or the spiral line because of the direct involvement of those lines with the scapula. Fascial line stuff. I just want to, for a second, read from this book one more time about the arm lines. Complexity of the structures along the arm is mind-boggling. The arms have to control the finest instrument the world has ever known, the human hand, at one end, and are anchored into the neck, the head, the upper spine, the ribs, the low back, the hip, the sacrum, and even arguably the femurs at the other end. So again, when we think of the arm from a clinical standpoint, we typically just think of the arm. And we only view it as the structure of the upper extremity. But we have to understand that because of the fascial lines, we have direct anatomical links and direct anatomical connections to structures that are far-reaching. That's why oftentimes when we run into patients with shoulder pain, shoulder issues, post-op shoulder issues, considering what's going on at the trunk, considering what's going on at the neck, has to be in the forefront of our thoughts. I've gone as far as to say, from a clinical standpoint, if you have a patient that has had shoulder problems, until you've cleaned up the neck, you still have shoulder problems because of the influence of the neck on the shoulder, because of the influence on the shoulder on the neck. If you have a shoulder issue, you have to consider the neck. If you have a neck issue, you have to consider what the trickle down is into the shoulder. And oftentimes clinically, we get hung up on, well, it's just an elbow. Let's just address the elbow. Let's lock in on the elbow, and let's not think much. Let's think one joint above, one joint below. The one joint concept was a great concept in the 80s, but we're not in the 80s anymore. We have to, it was a good step, but it's time to take a step a little bit further, not just think randomly one joint above, one joint below, but actually think fascially, where does this connection go and what all is involved? Especially if you're dealing with somebody with some kind of non-acute type situation. In the upper body, what that ends up being is our rotator cuff issues. Not a rotator cuff tears, but shoulder pain, posterior shoulder pain in our throwers. Well, we always write that off, well, they're throwers. They're supposed to have shoulder pain. Not necessarily. There's probably more throwers out there that don't suffer shoulder pain than do suffer shoulder pain. But we write it off as, well, that's just part of throwing. It's not. Shoulder impingements. Any stuff going on, numbness, tingling in the upper extremity from the brachial plexus. We're not going to talk about frozen shoulder. The epicondylitis is of the elbow, tennis elbow, medial epicondylitis, lateral epicondylitis, golfer's elbow, carpal tunnel. Oftentimes, these are very frustrating things for us to deal with and work with because we only look at that shoulder impingement as a shoulder issue. We only address the shoulder. We only do things to address the shoulder. We only do things to address the carpal tunnel. And they're very frustrating from a clinical standpoint to deal with, but they're also extremely frustrating from a patient standpoint to suffer through. And one of the reasons that it's so frustrating on both sides of that equation is because if we're only addressing the shoulder when it comes to shoulder impingement, we're likely not including all of the causative factors. We can take away some of the issues, but the likelihood of us actually completely resolving this is very, very slim if we don't look beyond just that shoulder. That's why we have to consider everything in that fascial line. When we talk about shoulder impingement, yes, anatomically there's impingement going on in the shoulder, but it's not a shoulder issue. It's an entire arm line issue. We have to address the entire arm line. And more than likely, we're going to have to address at least two of the arm lines. It's not just going to be a one arm line issue in isolation. There's usually going to be at least two arm lines involved when we're looking at this. So if we go in with our eyes wide open and we have that patient with medial epicondylitis, this isn't an elbow issue. This is a front arm line issue. I have to look at and consider and address clinically the entire front arm line and everything that entails. And when we do that, we start finding these random things in these places that we never would have looked at before that have significant effects. Posterior shoulder pain. You have that person that has posterior shoulder pain. If you go out to the backside of your humeral head, kind of where the rotator cuff tendons are, not, spine of the tip of my scapula is right here, spine of my scapula is right here, just below the spine of the scapula. You get that deep shoulder pain. It just is a pinch. It hurts all the time. I can't get it to go away. You see it a lot with post-op shoulder patients. You see it a lot in throwers. Just won't go away, won't go away. We do all the stretching. It won't go away. Well, from a fascial line standpoint, if we come right down here to the thenar muscles of the hand, there's a very high correlation between non-acute pain on the posterior shoulder and finding that junky trigger point right here. If you take care of this, oftentimes we see the symptoms of the shoulder significantly go away, especially if they get pain as they go into external rotation. So they have that posterior shoulder pain, you check them in external rotation makes that pain worse. They have a posterior impingement test that's positive, all of that, you're taking posterior shoulder impingement. Look down at the thumb. If that doesn't feel great, spend some time there, reassess. I will almost guarantee you, if you spend adequate time here, and when I say adequate time, about 30 seconds, what they feel in the back of their shoulders is going to be significantly better. And it has nothing to do with a rotator cuff muscle that attaches all the way down here. We're changing things from a fascial line standpoint. I want to talk about the brachial plexus real quick. Brachial plexus, C5 through T1. I'm not going to make you guys go through and rehash the trauma of memorizing what nerve roots leads to what named nerve and how they cross and all the little branch offs from that. Like we all probably had to do at some point in our undergrad. I'm still traumatized by the picture of the brachial plexus that we had to fill in, all the nerve root levels, all the named nerves, all of that. I don't know how long I studied for that. I'll be honest, after I probably failed that test, I never thought of that again because I used resources to look at it. And that's why we're not going to talk about it from that standpoint. What I do want to talk about the brachial plexus is the traditional thought of the brachial plexus is we have to be concerned about the brachial plexus when there's neck injuries, and we have to be concerned about the brachial plexus when there's impingement type stuff. And other than that, the brachial plexus doesn't do anything. And again, that's an area of our formal undergrad education as athletic trainers and in the healthcare profession that I think comes in a little bit short when we're talking about the brachial plexus. Brachial plexus, when we look at it, again, it provides the entire innervation of the upper extremity. When patients have symptoms, specifically neurological symptoms, anywhere in the upper extremity, where they have those symptoms can give us an idea of where we need to investigate at the neck. We've all hit our funny bone at some point, and it leads to the numbness and tingling out here into your pinky finger and your ring finger, the ulnar nerve. C8 to T1. Now, that's clearly developed because we hit where that ulnar nerve is very superficial. We hit the ulnar nerve, it creates distal sensation changes, which is a numbness and tingling in the brain. We've all at some point fell asleep where there was direct pressure on this. We wake up, our hands asleep. We've all slept with our arm in a funny position. Some part of our hand or shoulder, hand or forearm is numb and tingly, and then it starts to, can't even feel it at all, and then it starts to come back and get numb and tingly because we're putting direct pressure on these nerves. Well, we have to understand that where we're getting these nerves, yeah, we look at it, oh, it's the ulnar nerve. We think it's the ulnar nerve. Wonderful. What are you going to do if it's the ulnar nerve? And then my next question is it actually the ulnar nerve that's the issue? Or is it something positionally along the path of that ulnar nerve that is creating some type of compression to the ulnar nerve that's leading to those symptoms, especially in cases like carpal tunnel? We know that there's places of impingement in the body, especially when we're talking about the upper extremity. The carpal tunnel is a great example. Not a lot of space. You spend all day with your wrists extended, you compress that space even more. We run into carpal tunnel type syndromes. Guess how successful the carpal tunnel treatments are? Why? The surgeries work well. They go in, they do a release of that flexor retinaculum that creates some space, that gets rid of the compression, and oftentimes that comes back. Why? It goes back to the fact it's not just a wrist issue. And all they're doing is addressing the compression at the wrist. Yes, that's the easy target because we can see this, and this gives us warm, fuzzy feelings about, oh, it's a wrist issue, this is a simple solution. Well, if it's such a simple solution, why is it such a frustrating thing from a healthcare standpoint to deal with? And why is the success rate not 100%? Again, it goes back to we can't just think about this as a wrist issue. That might be that might be one of the causative factors, but we have to address this over the entire upper extremity, over the entire neck, over the entire trunk. When we talk about the brachial plexus, again, we're always concerned about how many of you guys have actually dealt with an athlete that actually has had a brachial plexus injury because of a direct blow to the brachial plexus. I think in my entire career, I've had maybe one or two, and they were both in wrestling, where somebody actually got hit in the brachial plexus with an arm, an elbow, or a knee. They had neuropraxia. The entire upper extremity was exactly textbook, like all the textbook stuff we learned about brachial plexus injury. That's only happened once or twice in my entire career. And I spent quite a bit of time covering wrestling, and it's only happened a couple times. What we need to understand, the more common presentation of a brachial plexus injury or a brachial plexus issue is going to be impingement on the brachial plexus. And it's not going to be impingement, bony impingement like we typically think of in the shoulder. Well, they have impingement of the shoulder. When we talk about impingement of the brachial plexus, we have to understand where it passes. It passes behind the coracoid process, behind the pec minor, deep to the coracobrachialis, the short head of the biceps attachment onto the coracoid process. Remember, coracoid process is part of the scapula. If there's any kind of tightness in there, that's going to bring those structures forward. That's going to cause a rounding of the shoulder, which is going to shorten that pec minor even more, which is going to create compression or pressure onto that brachial plexus as it's passing behind that. So anytime we see anybody with a rounded shoulder posture, we know that that pec minor is carrying extra tension, and there's likely going to be tension or compression on that brachial plexus in this area. So when we see that person with rounded shoulders, we have to understand there's a good likelihood that there's some kind of neural involvement, even if they're not to the point that they're developing the numbness and the type sensations out in their hand. We have to keep that in the back of our mind as something that is going to, or has a chance of developing. The other place that we see it is going to be the scalene. Scalenes aren't part of the arm line, part of the lateral line, deep front line. And when we look at this, the brachial plexus actually comes out between the anterior scalene and the middle scalene. So if you have your three scalene muscles, the brachial plexus actually separates those. So again, if we have any kind of tension in that lateral neck, we can see excess tension in those two areas, which are going to put compression over the brachial plexus. And again, if we consider the neck and the shoulder as one functional unit, if you have a neck issue, you have a shoulder issue, or if you have a shoulder issue, you have a neck issue, we again have to take into consideration whether or not there is going to be any kind of impingement here. And even if we're not to the, and why I say we have to have this as a consideration, because if it's progressed to the, if impingement on the brachial plexus has progressed to the point that they have the numbness, the tingling sensation, that's an easy one to diagnose. We see that, we understand that, that's no big deal. How many of you guys have seen that person that has the arm tingling and the numbness is just randomly there? We don't see that very often. So then, Brandon, why are you talking about this? We don't see this very often. because that's if it progresses all the way to that point. Usually we don't get there. What we need to consider, though, isn't what happens from an output standpoint, it's from an input standpoint. If we have tension or compression on the brachial plexus, either at the pec minor or at the scalenes, yeah, it can create numbness and tingling distally as an output. But if we haven't quite progressed to that point, but there is the rounding posture here, there is the lateral neck tension, we are getting a little bit of tension on the brachial plexus. That's going to affect the ability of those tissues to carry the input to the central nervous system. It's going to have an input, it's going to have an effect on our sensory input. So, and we're going to be dealing with that anytime we see a change in this posture. Only if it progresses far enough will we actually get to the point where the compression has gotten to the level that we get the numbness and tingling. What we're dealing with in all these situations, though, are people where we have to be concerned about the quality and the level of sensory input that they're getting, secondary to the compression from the scalene, from the pec minor, from these faulty positions. At the elbow, ulnar nerve goes to the lateral hand pinky finger. We often think about it specifically when we hit our funny bone because it is very superficial. But if we look at it, where it comes to, it runs in between the triceps and the biceps. Up here, it goes just behind the coracobrachialis, in front of the teres, in front of the rotator cuff. If we have a rotator cuff issue, if we have somebody that has a rotator cuff issue, if we have somebody that has shoulder range of motion issues, we can start getting some level of impingement here. And again, not necessarily worried about impingement to the point that it causes a numbness and tingly stuff. That's easy to diagnose. If I have numbness and tingly in my pinky finger and ring finger, we know it's ulnar nerve. It's just a matter of figuring out where that impingement is coming from, where that compression is coming from. What I'm more concerned with is if shoulder range of motion is limited. If we have a biceps tenodesis where we know there's been surgical insult here, what's that doing to the quality of information, quality of sensory input that we're getting to the nervous system? Because remember, if the quality of sensory input is negatively affected, it's going to change how we process things and it's going to change our output strategies. So we always have to bias our input. Any type of scar tissue, any type of adhesions along that pathway can affect this. Yes, we can get to the point where we do get the neurological symptoms because of the impingement, but oftentimes what we're dealing with is an issue with the input. An issue where the input is impaired and we need to do things. We've identified things where we know that there's a likelihood of this, but we aren't taking the next step to actually address that. With the shoulder, we have our static stabilizers, which are essentially the glenoid, the acromion. You have the labrum, which increases the size of the glenoid fossa just a little bit, and then we have the capsule of the shoulder that surrounds the entire shoulder. These are static stabilizers just because they don't have the ability to elongate. They can move, they can adjust, but they don't have the ability to elongate. So at some point, if there's too much stress, you're going to see a labral tear, you're going to see a capsule tear, you're going to see damage to the glenoid. There's not enough static stabilizers of the shoulder to actually stabilize the shoulder. They're not equipped for this function. And part of the reason why is because how much we rely on the mobility of the shoulder. The shoulder and the hip are mirror images of each other, but exact opposites of each other. The hip is a very stable joint. The hip is designed to bear all of our body weight on one leg. So the static stabilizers of the hip are very robust. But the hip sacrifices mobility for that. How many of you guys have dealt with a hip dislocation? One. How many of you guys have dealt with a shoulder dislocation? We've all seen shoulder dislocations. They're a dime a dozen. It's hard to dislocate a hip. The mechanism for hip dislocations are some kind of traumatic episode. You see it very often in motor vehicle accidents. Otherwise, it has the stars have to align just right in the sporting world for that to happen. But shoulder dislocation, somebody sneezes wrong and we see a shoulder dislocation. Again, it goes back to the degree how well equipped those static stabilizers are. The hip's designed to bear weight. It's designed from a very robust standpoint to be able to do that just on the static stabilizers alone. The shoulder's not. We sacrifice that stability for the freedom of motion that we want, which means we have to rely on the dynamic stabilizers. The stability of the shoulder is very heavily influenced by the dynamic stabilizers of the shoulder. Pretty much any muscle that crosses the shoulder joint, attaches to the scapula, attaches to the clavicle, attaches out to the humerus anywhere, those are going to be your dynamic stabilizers. We have the large ones on the outside, the pec, the deltoid, the lats, the triceps, the biceps, and then as we go deeper, we get all the way down to the rotator cuff. One of the problems that we have is we've assigned some incorrect beliefs to the dynamic stabilizers of the shoulder. What's the primary off of this list? What are we taught is the most important structure to stabilize the shoulder? Rotator cuff? We all hear about rotator cuff programs. Rotator cuff strength. When was the last time you heard about a deltoid strengthening program? Ever? No. Our focus is on the rotator cuff. We train the rotator cuff. We do all this stuff. When was the last time we ever did anything from a lat standpoint? Let's strengthen the lat. We don't do it. We worry about lat flexibility, but we don't worry about anything else with the lat. From a shoulder standpoint, all we focus on is the rotator cuff. And that's not a wrong thing to consider, but if that's the sole focus of what we're doing with the shoulder, you're never going to win that. Because like we've talked about several times, the entire mass of the entire rotator cuff isn't the size of the pec, isn't the size of the deltoid. They're never going to win. The entire rotator cuff is never going to be able to generate as much force as the middle delta in isolation. But yet we still focus on trying to strengthen a muscle or strengthen a muscle group that has very little to do about strength. The rotator cuff needs to be quick. And so when it comes to dynamic stabilization of the shoulder, it's all about how things work synergistically together. If there's an imbalance in the shoulder, we're going to run into problems. And that's one of the reasons why we see this huge focus on the rotator cuff, because we don't understand the interplay between the deltoid and the rotator cuff. If we take away the rotator cuff and the deltoid by itself were to contract, we would dislocate our shoulder. If we think about the anatomy of the shoulder, we have a bony ceiling from the acromion and the clavicle. Medially, we have the glenoid. Laterally, we have the humeral head. What supports the shoulder inferiorly from a static standpoint? There's nothing until you hit rib cage. So if we get a maximal contraction of our deltoid, take our rotator cuff, we get a maximal contraction of the deltoid, what's going to happen is the forces going through the head of the humerus are going to cause the head of the humerus to slide inferiorly, inferior dislocation. That doesn't happen though, because as the deltoid engages to either abduct the arm or flex the arm, the rotator cuff also engages. And the line of pull for the rotator cuff is to pull it medially. So as the deltoid is trying to dislocate it medially and inferiorly, the rotator cuff at the same time is turning on and sucking that humeral head into the glenoid fossa to prevent that anterior-inferior dislocation. The rotator cuff doesn't do that, we get an inferior dislocation. So these two muscles have to work together. The deltoid is bringing the force, and the rotator cuff is directing. When that doesn't happen, we run into problems. Unfortunately, again, I go back and ask the question, when have we ever instituted from a rehab standpoint a deltoid strengthening program? We don't do it. We do rotator cuff strengthening because we think we need to strengthen the rotator cuff. We need to make sure the rotator cuff can turn on and turn off at the right time when the deltoid is doing what the deltoid needs to do. Where is it? I think this is on another slide, but it doesn't make sense that it would be on another slide. It should be on this slide. We're going to come back to this recent article that talks about this, and what this article looked at it was how much the deltoid contributes. Is it in here somewhere? How did I forget that? Guess I just needed to go forward one whole slide. So when we look at the deltoid and the rotator cuff, the study actually went in and they looked at how much the deltoid contributes to shoulder flexion, how much it contributes to abduction, how much it contributes to external rotation. And what they found was when we talk shoulder flexion, at about 120 degrees of shoulder flexion, the deltoid is contributing about 70% of that force. 30% is coming from other structures, part of that being the rotator cuff. In abduction, the deltoid contributes about 75% of the force required when we get up above the shoulder. Now, both of those, it's a linear change. So when we start abduction, all the way down here, the deltoid's at a huge mechanical disadvantage. It contributes about 24%, and it progressively increases about 75%. In flexion, it's about 11%, 10-11%, and it moves up to 70%. Flexion, you also have all the muscle. You have the biceps, short head of the biceps, coracobrachialis, all those that contribute as well. So it has a little bit of help. But in either instance, if you take away the deltoid, you take away the largest component of the structures that generate the force necessary to raise the arm. The rotator cuff, those other structures that generate the last 30% are too ill-equipped to actually move the shoulder. If you have a weak deltoid, you're going to have problems. All of our post-op shoulder patients, it's a deltoid strength issue. When they look at external rotation, we're trained to think if we're going to work on shoulder external rotation, it's the infraspinatus, supraspinatus, right? Those are our shoulder external rotators. They're not. Deltoid and teres minor contribute a majority of shoulder external rotation forces. When we think internal rotation, it's subclavius. Not subclavius. I can't even think of the name of it. Subscapularis. Is that right? Doesn't sound right. We think it's subscapularis. But remember, where the pec and where the lat insert. Which is going to bring more force to internal rotation? Your subscapularis, that I can't even remember the name, of your lat. The lat and the pec are the primary internal rotators of the shoulder. But we go back to thinking it's the subscapularis and it's the infraspinatus and the supraspinatus that are affecting our shoulder rotation. Again, they need to be able to turn on and turn off appropriately to keep the pressure on the humeral head to keep it sucked into the fossa. But they're not the ones bringing the force to the equation. And if they are, we have a problem. From a range of motion standpoint, what they did, they went in and they basically paralyzed the deltoid and then looked at range of motion. And there was a significant, when you take the deltoid's contribution the shoulder motion off the table. There's a significant decrease in all shoulder ranges of motion without the deltoid. Flexion was impaired significantly, abduction was impaired significantly. Internal and external rotation weren't as significantly impaired at 0 degrees, but at 90 degrees they were, which makes sense. At 0 degrees, infraspinatus, our little rotator cuff muscles, they don't have to overcome a lot of resistance. But up here, it's a whole different story. So anytime we have a rotator cuff issue, we have to consider deltoid. We have to consider the deltoid from a strength standpoint. We need to get the deltoid strong so that the rotator cuff quits trying to be a deltoid and can actually be a rotator cuff and learn to turn on and turn off. If you have a shoulder patient, post-op shoulder patient, shoulder pain patient, and we're not addressing deltoid strength, you're not helping that patient. They're not going to fully resolve themselves because the rotator cuff is not strong enough to function like a deltoid. We have to consider the deltoid anytime we have a rotator cuff involved. When we think about impingement of the shoulder, we think about the bursa. We're impinging the bursa of the shoulder, the severed bursa of the shoulder. We can see where they sit. There's not a whole lot of space between the head of the humerus and the bottom of the acromion. It is what it is. Where'd this go? Is what it is. But when we consider the bursa is the easy target to blame. It's there. If we get impingement, we have to be impinging the bursa. Anybody know anything about the innervation of the bursa? There's not much. So even if we're impinging a structure where the innervation is kind of sketchy, how uncomfortable do you think that's going to be? Not very. So yes, we need to consider the bursa, but if that's a secondary consideration. First and foremost, from an impingement standpoint, we have to understand likely what we're impinging is the actual head of the humerus into the acromion. We're likely impinging the rotator cuff tendons. The tendinous insertion into the periosteum is where we have the highest degree of nerve fibers, the highest density of nerve fibers within the muscle. Those tendon is going to be tender if we impinge them. Same thing with the biceps tendon, the long head of the biceps tendon. If we're going into flexion, the likelihood is we're impinging those structures, not necessarily the bursa. Okay, wonderful. We've identified which structures that we're impinging. How does that help us? We have to also understand if we're talking about an impingement issue, this isn't a shoulder issue. This is a positional issue. If 3 weeks ago, this athlete that just walked in and wants assistance, 3 weeks ago the shoulder felt fine. I wasn't having any problems. Now they have all the positive signs of impingement. Something changed in 3 weeks. It's a positional issue. Something changed in how they're carrying their shoulders. Something changed to decrease this space to lead to that impingement. That's what we have to address and fix. So anytime we're dealing with an impingement issue, it's a postural issue. We have to figure out what's causing us to lose space in that area. And oftentimes what causes us to lose space is some kind of rounding of the shoulders. And I'm going to once again, go back to our post-op shoulder patients, because I think how we care for post-op shoulder patients is we have lots of room for improvement. If I have shoulder surgery, what are they going to put me in? A sling. I'm going to get in that sling, and where does the sling position my arm here? No, where does the sling position my arm? Here. If I straighten my arm out, what do I have? A rounded shoulder. So I have a shoulder that just had labral repair, that just had Bankart repair, that just had rotator cuff repair, that just had a biceps tenodesis, just had this significant surgery, and they put me in a sling that puts me here. I'm creating impingement. So now I have the surgical insult that I'm having to deal with, the trauma to the tissues, and now on top of that, we're creating secondary impingement. So we have to consider that. Because guess what? Hey, Dr. Seagrave, you've got to quit putting your post-op rotator cuff repairs in the sling because you're creating secondary impingement. Guess what he's going to say? Secondary impingement is better than a failure of that rotator cuff if we leave him in the sling. And he's not wrong. But at the same time, we have to find the happy middle ground. We want them up in their sling to protect the shoulder, to protect that repair when they're up, when they're moving, when they're doing stuff. But if most people, after they have surgery, their activity level is going to drop considerably. Because it's just, A, it doesn't feel good, and B, it's just inconvenient for me to do a lot of things. So we spend a lot of time sitting in our chairs, sitting on the couch, just sitting because it's easier. If I'm just sitting, do I need to be here? No. So we educate them, hey, if you're sitting down, if you're not doing anything, take the sling out, let that arm sit back here. I want you to spend as much time with your elbow by your ribs or behind your ribs as you possibly can. Now, if you get up, if you're moving around, if you're at school, if you're at work, put your arm back in the sling. But we need to spend some time here to prevent that secondary or pull back the symptoms from that secondary impingement. Also, from a rehab standpoint, we know that we're losing a battle because they're spending multiple hours a day in this position. We know we have to work on things to offset that. We have to work on getting that rhomboid, getting those posterior structures to work on scapular retraction because we know what's going to happen. Drives me nuts. We get so frustrated. Oh, they've got impingement. We didn't know what was happening. How did you not know it was happening? It's been sitting in front of you for 8 weeks. We can't act surprised because we didn't want to see that for 8 weeks. We have to start that right away. The red parts are where the deltoid attaches. But again, all I want from an impingement standpoint, we don't have a whole lot of space here. Anything that is causing our shoulder to move forward is going to get us into some level of impingement. We see that. If we know that that's happening, we have to work on offsetting that. Ooh, loading of the wrist. You guys remember when we get down in quadruped? How do your wrists feel? It's okay initially, but eventually it starts to not feel good, right? So what's our solution when it doesn't feel good? We get into quadruped and something like this. We get onto our knuckles. Oh, that feels so much better. Still a little bit of relief. Yeah. We're not, there's a reason why we're bipedal and not quadrupeds. Because we don't have a wrist that's designed to support our body weight. Remember, the function of the lower extremity and the function of the upper extremity are not the same. The lower extremity is designed to bear our body weight. That's why the structures of the lower extremity are so big and so robust. From a bony standpoint, from a static standpoint. Little bitty carpal bones of the wrist are nice and dainty. They're not designed to load and carry our body weight. They're designed, again, like the shoulder, for mobility. They're designed to get our hand and allow our hand to do all those fine motor skills. They're significantly smaller than the tarsals of the foot. Look how big the calcaneus is. This isn't a scale model. I just put this up here. Look how big the calcaneus is compared to any of the bones, any of the tarsals of the wrist. Look at the talus. The talus by itself is bigger than all of the carpals of the wrist. Because it's designed to bear weight. It's designed to be loaded. The wrist is not. So when we look at the foot, center of pressure of the foot is around the base of the fifth or slightly posterior. It's not out into the tarsals, into the metatarsals. We bear weight through here, which directs a lot of the force up. We have a little bit of force coming through the tarsals and metatarsals that we redirect, but the calcaneus That's one of the reasons why the calcaneus is so big and so robust, so it can handle that transfer of energy. The calcaneus is designed to interact with the tarsals of the foot and absorb that force. It's designed to interact with the talus. And that connection between the calcaneus and the talus is designed to interact with the tibia and handle that force, that grounded force. That interaction between the calcaneus and the talus is where we get that force redirection. That's one of the reasons why the calcaneus looks the way that it looks. It's a very uniquely shaped bone. The calcaneus allows that redirection of forces when we're up on our toes, when we're running, when we're walking, because it's designed for locomotion. The wrist doesn't have that. The wrist isn't designed to be loaded in an extended position. But when we're in quadruped, we do that. Well, Brandon, babies crawl. You're right, they do. And what do they replace crawling with? Walking. And the reason that babies crawl is because that's the only thing that's accessible to them at that point in time. They also don't have fully developed carpal bones. They have 3. They have less space. So they can get into full wrist extension. It's easier because they don't have as many bones and they don't have as much compression of those tender, sensitive structures because they haven't fully developed yet. But then they fully develop. We get our 2 rows of carpals. They're very sensitive to loading. Makes extension a little bit more difficult, makes extension under load uncomfortable in some instances. Yes, we can get down in quadruped, and yes, we can do things in quadruped. I'm a huge proponent of that. But we don't necessarily need to consider loading quadruped up significantly because of what it's going to do to the wrist. We do have to take that into consideration. Now, we do need to be able to have full wrist extension. You should be able to get 90 degrees of wrist extension just from a sheer range of motion standpoint. We should be able to load the wrist, and we should be able to do all of that. I'm just saying we probably don't need to time how long it takes somebody to crawl a mile, or see how heavy of a sled they can drag on their wrist, or how much we can load them on their wrist, because that's not what the wrist is designed for. All right, grip. You guys have your numbers, right? This is where we're going to come back to these. Grip strength is a reflection of mortality rate. The 2 are intricately tied together. We're going to go back to the article, different article. This one's on grip strength values of 200,000 German nationals. Several years ago, I was at a workshop that, hand grip's important because it's a predictor of life expectancy mortality. I was like, man, I wish somebody would explain that to me. And now I'm talking to you guys about grip strength. So I want to read this to you guys a little bit. Hand grip strength has been reported to predict multifactorial decline in various health parameters necessary to maintain daily activities such as cognition, mobility, and functional status. Besides functional deterioration, low hand grip strength has further been associated with an increased risk of premature death and longer hospital stays. As an indicator of disease, hand grip strength represents the main component of sarcopenia. Sarcopenia is an age-related decrease in muscle mass, muscle strength. Up until very recently, sarcopenia wasn't a discussion that we had until you got into your 50s. Guess what? It's starting to slowly creep in because of lifestyle, because of activities, just because of how we've changed as people. We now see sarcopenia starting to present some of its signs and symptoms as early as in our 30s. It's very reflective of activity level. The higher your level of activity, the lower the likelihood of sarcopenia. The less active you are, the earlier the onset of sarcopenia. But either way, sarcopenia is not a good thing whenever it happens. Grip strength, again, if we think about what the upper extremity does, the upper extremity is designed for mobility, for us to interact with the world around us. If grip strength declines, it limits our ability to interact with the world around us. We have difficulty picking things up. Okay, so we're not going to the gym and we're not deadlifting a lot. But what about when grip strength gets to the point that picking up that cup of coffee is even hard? Because then that starts to affect day-to-day activity. And what do? We start changing what we do. we start changing our activities. And those changes come at a cost. And what ends up happening is grip strength is an indicator of overall strength and muscle mass. And when grip strength gets so low that it creates change, that's a reflection that muscle mass of the entire body is so low that it's creating systemic change in how we're able to interact and move through the world. And when we're no longer able to care for ourselves, what's the next step? Assisted living. When you look at individuals that enter the nursing home, now, oftentimes when people enter a nursing home or a care facility like that, there's usually other health issues going along with them. It's not just because I'm having trouble taking care of myself anymore. But when an individual, so when we're talking about entering assisted care facilities or nursing homes, there oftentimes are other comorbidities that are contributing to that. But for the past 30 years, consistently, there's been one marker that hasn't changed. When people enter a nursing home, when people enter a nursing home, life expectancy is about 1 year. Odds are 1 year mortality rate when somebody enters a nursing home. Now, part of it is because you take that person that has these health issues that are needing to enter assisted living, but what happens is you take them out of the world that they've lived their whole life. So their social circle is different. It's a completely different environment, completely different schedule, different food. It's a huge shock to the system. So you have all of these factors that go into this. But one of the things that contributes to when people need to enter an assisted facility is overall muscle quality to where we're no longer able to care for ourselves, which is where grip strength comes into play. Grip strength is a huge predictor of this. So now, when you did your grip strength, if you're a male, that's pounds, not kilos. If you're a male, 29 pounds. If you're a female, 18 pounds. Below those, you're considered low strength. That's the worst category to be in. If you're in the low strength, and why is that the worst category to be in? Because there is a direct inverse relationship, a linear inverse relationship between grip strength and mortality rate. The lower your grip strength, the higher your mortality rate. As grip strength increases, mortality rate decreases. So they're the exact opposite of each other. So the lowest category is classified as low strength, if your grip strength is under 29 pounds if you're a male, under 18 pounds if you're a female. That's just minimal standards. From a reality standpoint, from a reality standpoint, if you want to be able to perform all the skills of being a human, your grip strength needs to be at or above 50% of your body weight. That's the consideration. So look at the numbers you have on your paper. Is the grip strength on your right hand more than 50% of your body weight? Is the grip strength on your left hand more than 50% of your body weight? If not, that's something that can be worked on that will make just normal day-to-day life a little bit easier. And as long as you're above the 29 pounds and the 18 pounds, you're not in the low strength category.
So even the age, even the older person still need to over that?
Yeah, it's not related to age. Across all age groups, it's considered the same. Why 50% body weight for grip strength for normal day-to-day function? Well, one of the considerations from a strength standpoint, one of the strength expectations is everybody needs to be able to at least pick up their body weight from the floor. Why? I don't do CrossFit. I don't care about being able to deadlift my body weight. It has nothing to do with being able to deadlift your body weight. It's about having to pick up that object from the ground. More importantly, it has to do with I'm walking, I trip, I need to get my foot down quickly, and I need to be able to absorb that force. So I need to be able to at least deadlift my body weight, because every study when we look at jumping, when we land, we're landing with anywhere from 2 to 5 times our body weight. So I know if I trip, I'm not falling, but I'm still having to absorb more than my body weight. So if our minimum buffer is an additional body weight, so for me, 480 pounds, if I'm deadlifting my body weight, I'm picking my body weight up, 480 pounds is going into the floor between my 2 feet. That gives me a little bit of a buffer if I trip and step down, I know I at least have that. What does that have to do with grip strength? Well, if I'm picking up my body weight dispersed between 2 hands, I need about 50% of my right hand, 50% of my left hand. So for me, I need to have a grip strength of at least 120 pounds on my right hand and at least 120 pounds on my left hand. So that's where those numbers come from a day-to-day movement standpoint. All right. Any questions about the arm line? Again, with the arm line, they're complex. They're named for where they pass in relation to the shoulder joint, anterior, posterior. If you have an issue anywhere in the arm, it's not a wrist issue, it's not an elbow issue, it's not a shoulder issue, it's an arm line issue. We have to consider the entirety of that arm line. Questions or anything about the arm lines? All right, last slide of the semester. Why are we talking so much about anatomy? We've literally spent the last 4 weeks talking about anatomy. And you guys have all had anatomy classes. You've all probably had a cadaver anatomy class. We've all got this. But yet we've still spent the last third of this class talking about anatomy. This is a patient just was seen yesterday. I just got these pictures on my phone yesterday. I was like, oh, this is a great example for today. 8 weeks, post-op knee, post-op ACL reconstruction. Used a quad tendon because, as you can see, there's an old ACL scar here. So I already had a patellar tendon graft. Did a quad tendon graft this time. We have our portals here. We have this giant incision here. You guys can see that pocket of swelling right there. Kind of jumps out at us. You might know what this incision is from? Not quite a hamstring. So we know that they had an ACL before. It failed. And it failed using the gold standard. And it still failed. So one of the reasons that they felt that it failed, one of the reasons the surgeon felt that it failed, is there's a little bit higher level of rotary instability. Couldn't do this, didn't want to harvest a hamstring, wanted to harvest a quad tendon, so we could get a little bit of patella for that, for a little bit stronger fixation point. One of the things that's coming back from a surgical world is when the surgeon's wanting to control some of that rotary instability, it's an IT band tenodesis. So basically, IT band sits here. Think of the IT band in thirds. They take the middle third of the IT band, detach it, loop it through, attach it onto the medial side of the joint, I believe. They run a tunnel through there, and that helps to control some of the rotational component of the tibia, decreases the rotational component. But they take the middle third of that IT band. That's what this incision is for. Okay, remember the IT band comes out and attaches all the way down. So they take that, they open that up, they do that tenodesis, they split the IT band, they get a section of the IT band, they go through the joint capsule, run that through to the medial tibia, I think it's medial tibia, insert it with a button, drill the tunnel through there, insert that, and then close that up. So now, and it's one of the things they used to do with an ACL reconstruction, they did something very similar, but they did it extra articularly, where they would take that and they would wrap around the front of the knee, fix it, and it led to all kinds of problems. That's not what this procedure is. It's quite a bit different, actually a lot better. But now it's starting to become a thing when there's a rotational component of instability. That's what the procedure was. This patient's 8 weeks out. Isolated swelling to the lateral knee. What is it? Because we've run all the tests for infections. Guess what? There's no infection. It's been drained a couple times. Guess what color guess what color the fluid is? Do you think it's bloody or do you think it looks like urine? Looks like urine. It's just straight up synovial fluid. So there's no bleeding inside the joint that would explain why this is just continuing to fill up. It's not bleeding within the joint. It's not an inflammatory response. It's not an infection. Why do we have the persistent localized pocket of swelling? What is it? This is where anatomy comes into play. Because, remember where the IT band attaches, right? Blends into the lateral joint capsule, right? To drill a tunnel to get to the medial side of the joint, do they go through the joint capsule? They have to. So they put a hole in that joint capsule. What's the function of the joint capsule? It provides a little bit of stability. It's like a balloon around the joint, but it also keeps the synovial fluid inside the joint, right? They put a hole in that. What happens to a balloon when you put a hole in it? It pops or it leaks. If it's a water balloon, you just see this flow of water coming out. That's what we have going on here. Because when they do this, they don't suture the joint capsule closed. They might, depending on how big that gap is in the IT band. So if they take the middle third of the IT band, depending on the physician, they might leave this open to fill with scar tissue, or they might lightly suture those together. They don't want to crank the sutures down because then that changes the dynamics of the IT band, and they don't want to do that. So if anything, they'll do loose suturing through here, but more often than not, they're leaving this alone. So they don't close the deeper layers like they do with the graft sites. Because with the graft sites, they close the deeper layers, they close from the inside out. With this, they don't. So guess what happens? That joint capsule continues to have a hole in it. What's going to happen when this person moves and stands up? The synovial fluid is going to leak out. It's going to drain out and it's going to collect in that lateral area, which is exactly what we see. Well, what's going to happen inside the joint if the joint is continually losing synovial fluid? What's the body going to do? We need to make synovial fluid. There's not enough here. Body makes synovial fluid. He gets up, he moves around. It starts to leak out. Crap, we're low on synovial fluid. Let's fill back up. It continues to leak out. We have this giant cycle where this just continues to happen. It's not an inflammatory response. It's not an infection response. But we've run all of those tests. It's just the process of this individual, that capsule hasn't completely scarred down yet to close off and we continue to leak synovial fluid. His range of motion is not affected. He doesn't have pain. The only time he has pain is at end range knee flexion, and he has lateral pain, and it just feels like it's going to pop through the incision. Lymphatic work doesn't work on it. Because, well, lymphatic work works. We make this smaller because we enter this fluid into the lymphatic fields. The lymphatic field's carried away, but guess what happens as soon as he gets up and starts moving around? The hole in the joint capsule is still there, and it fills right back up by the next time he comes in. So clinically, what do we do about it? Let me rephrase it. Clinically, is that a problem? We want to say yes, right? You see this. You want to say this is a problem. We all do. But clinically, is it a problem? It's not affecting range of motion. It's not affecting anything else. It's not painful unless we get into full knee flexion with overpressure. And then the pain is, it feels like it's pain in the skin from pressure. So again, I'll go back and ask the question, clinically, is this a problem? No. Should we devote a lot of time and energy to the resolution of this? We can do a little bit. I wouldn't clinically devote a lot of time and energy to it. Why? Because it's not affecting range of motion. We've run all that. We know it's not infection. We know it's not an inflammatory reaction. It's just the body's reaction to a loss of synovial fluid because it's constantly leaking through a joint capsule that still has a hole in it. So we might do some rock tape, We might do some stuff, teach them some self-lymphatic stuff for them to address on their own at home. But as long as we're not seeing a decrease in range of motion at the knee with this, we're going to continue to move forward with it, unless things change. Versus the mindset of, this is a big fat swollen knee, we need to address this, we need to devote a lot of time and energy to this. And out of the hour we have, we devote 40 minutes to this, and it's just not working. By understanding anatomy and what's going on, it helps us make a huge clinical decision that either we devote 40 minutes of time to a fusion that it's not going to matter, or we move forward with it. And the only thing that gets us to that point is understanding the anatomy of this area, the procedure, and how those two areas cross over. Otherwise, we're going to be wasting our time and getting further and further behind with this individual because it's not affecting things clinically for this person. We're going to avoid deep knee flexion. We're going to avoid anything that puts him into a position where he's getting that pain from this. But other than that, we're going to move forward with this. He's going to address this on his own. And over time, with the natural healing process, that should close up. The only other option would be if this doesn't close up, they could go in and they could suture that, they could try to suture that back up. I don't know if they want to do that. I don't even know if that would be a logical thought process to happen. But it's not a clinical problem.